Hello, my name is Kim Rajappan. I'm a consultant cardiologist and electrophysiologist at the John Radcliffe Hospital in Oxford, part of the Oxford University Hospitals NHS Trust. And I'm talking about supraventricular tachycardia, or SVT. What is it and what should I do about it? To understand the abnormal rhythms, it's important to understand normal rhythm as well. This moving cartoon on the right-hand side shows an electrical impulse that originates from the yellow dot, which is known as the sinoatrial node in the right atrium. That impulse travels as the yellow through the atria, making them contract. The impulse then travels through the green dot with a yellow circle around it called the atrioventricular AV node. And we see that as a little red impulse that then is transmitted through the green lines through the big main pumping chambers of the heart known as the ventricles. It's this coordinated contraction that keeps occurring. And by understanding that, we can then start to understand what the term SVT or supraventricular tachycardia means. Because tachycardia means fast heart rate. That is tachy meaning fast, cardia meaning heart. And supraventricular means, therefore, that it occurs above the ventricles. That is to say, it's going to be above or around that green circle with the yellow circle around it, the green dot with the yellow circle around it, there or upwards, not coming from the ventricles themselves. It is very common in the population. Indeed, many people probably experience symptoms and don't report them because they're so short-lived that they don't worry about them, and that's absolutely fine. There are some people who will come into hospital with it, but that's not very common. It's much more common that this is picked up in the community. People will speak to their GPs about it, and then they'll come and see us in the outpatient clinics to discuss further management if necessary. And we'll be talking about that shortly. Paroxysmal means intermittent. So some people refer to SVT as PSVT, and the P simply stands for paroxysmal or intermittent. There are some people who will have incessant or continuous SVT, but that is not common. By definition, as we've said, this has to be something that rises above or around the AV node. It has to be above the ventricles. There are basically 6 different types of rhythm that can be labeled as an SVT, or what some people refer to as narrow complex tachycardia. The first is a normal rhythm that goes fast. Normal rhythm is often referred to as sinus rhythm. In this case, we call it sinus tachycardia, a fast heart rate but still coming from the sinoatrial node. This is effectively normal in all of us when we do any form of exertion or do something that will speed up our heart rates naturally. It can sometimes occur a little inappropriately, but in itself, this is not a life-threatening or sinister condition. Atrial fibrillation is technically another form of SVT, although it is characterized specifically by more irregular pulse more commonly, and we know that in some people it does correlate with an increased risk of stroke. Atrial flutter, likewise, is another arrhythmia that is more commonly associated with some degree of irregularity, although sometimes people will notice that they just have a fast and regular heart rate. Like atrial fibrillation, in some people it may be associated with an increased risk of stroke. Often when people refer to SVT, they predominantly mean the next 2 mechanisms. The first is AV reentrant tachycardia, and the second is AV nodal reentrant tachycardia. I'll talk about those a bit more in a moment. Atrial tachycardia just means that there is a piece of tissue in the atria somewhere, either right or left atrium, that is firing off fast, separate to the sinoatrial node. It still generates a fast heart rate, often quite regular, and may behave a bit like a sinus tachycardia. So let's look at sinus tachycardia first of all. The sinoatrial node is here, as we mentioned previously. It fires an impulse that travels through the atria, making them contract first. AV node receives that impulse and then transmits it after a very short delay to the ventricles to make them pump. As we've said a moment ago, if the sinus node fires faster, technically, if it starts to fire at 100 beats or more per minute, then that is defined as sinus tachycardia. Let's talk about the two mechanisms, though, that we particularly often use the term SVT to refer to, even if it does, as an umbrella term, cover all 6 of those other rhythms I mentioned. Here, it's actually the most common form of a regular supraventricular tachycardia. It occurs more commonly in ladies than men. There are a number of ways of treating this type of SVT. In some people, they can actually control it and have found a way to control it by effectively holding their breath, what we call a vagal or Valsalva maneuver. And if you ask a doctor how to do that, they'll explain it to you. But one of the easiest ways to explain it is to pinch one's nose, close one's mouth, and try and blow out as hard as one can. And of course, you can't blow out, but if you try and do that for anywhere between 5 and 10 seconds and then suddenly take a breath, sometimes the SVT will stop. It's very definitely done best with the person lying down and with their legs elevated. It shouldn't be done with the person standing up, because there's a very small chance that they might pass out. We can use medication. We can inject a drug into the arm called adenosine through a small cannula or drip, and actually that may instantly stop the SVT. It's a very odd sensation, as patients will tell you who had it, but it can work very instantly. There are tablets we can give people to take in a slightly longer term fashion, perhaps, such as beta blockers, calcium channel blockers, and a few other drugs here that are more rarely used. And people take those, as I said, more commonly on a daily basis, perhaps in some cases, to try and stop the SVT from happening altogether. Some people may use a few of these, such as a beta blocker or calcium channel blocker, as a so-called pill in the pocket approach. So when the episode occurs, if it doesn't stop with some of the Valsalva or vagal maneuvers, and they don't want to come to hospital to get given adenosine, they may take one of these tablets, and after hopefully a relatively short period of time, the arrhythmia, the SVT, will stop. It is unusual to need to use electrical, what we call DC cardioversion. That's an electric shock to reset the heart rhythm, but just occasionally that is necessary. And importantly, in many of these cases, including for AVRT, we can perform a procedure known as an electrophysiology study and an ablation to actually try and cure the problem completely. AVRT, or atrioventricular reentrant tachycardia, is the other common form of tachycardia that people refer to as SVT commonly. Here, rather than 2 pathways in the AV node, a smaller percentage of us, probably somewhere around 0.5 to 1% of us, are born with an extra electrical connection between the atrium and the ventricles that can allow electrical conduction to flow, in this case through the AV node and back up through the accessory pathway, again setting up a circuit that causes the heart to race fast. Again, some people will be born with these accessory pathways, what some people refer to as Wolff-Parkinson-White syndrome, if you can see evidence of the accessory pathway on their plain ECG, and also they have palpitations. But many of them will lead their lives normally again without any adverse effects, specifically no increased risk of stroke or heart attack. But again, some people will experience palpitations at some point in their life through nothing they've done, and it just occurs. I mentioned atrial tachycardias, these small areas of tissue somewhere else in the atria, separate to the sinoatrial node, that just fire off fast. The impulse is transmitted through the AV node and down to the ventricles. This is one of the less common forms of SVT. It affects children, perhaps, and in some it can be quite incessant. In other words, not so paroxysmal, but actually occurring and actually going on for very long periods of time, even days or weeks. There are some young women, particularly some ladies who experience this in pregnancy, and perhaps it does slightly more commonly affect some of the elderly. One of the features of this is if the bit of tissue is firing off very fast and the AV node can allow that impulse to be conducted to the ventricles very fast, you get a very fast heart rate that's recorded by a fast pulse. And in some people, they may even feel quite lightheaded and almost like they're going to black out because their blood pressure drops. But actually, it's unusual for them to actually pass out, what we call syncope. And actually, very major drops in blood pressure are uncommon as well. If it does become incessant and go on for days or weeks, it can sometimes cause the heart pumping function to actually become reduced. Like any muscle, the heart muscle can tire, and we can see that in this case. We call this a tachycardia-induced cardiomyopathy. It is not common, it is quite rare, but when it does occur, it can lead to what people refer to as heart failure, which means that patients can be very breathless, the heart pumping function is severely reduced, and these people can be very unwell. The good news is that treated, it can be completely reversed. Again, in terms of medical treatment, we can use beta blockers. We can also use other drugs, and here in some people we can use flecainide, a very good drug for atrial tachycardia in some people, although we have to be careful not to use it in those patients where the tachycardia, the atrial tachycardia, has caused the heart pumping function to become decreased. Likewise, drugs like verapamil, which is a calcium channel blocker, can be used. Amiodarone works quite well, but there are some problems with long-term side effects. And for us, if we decide an ablation is the right treatment strategy, because again, an ablation can affect a cure in many of these patients, using amiodarone may not be ideal. And if we do an ablation, we actually very much recommend it for those patients who can't take drugs to suppress the arrhythmia or find the drugs are ineffective. If the drugs are very effective, people may choose not to have ablations. Atrial flutter, I mentioned, is a slightly different type of rhythm that may not commonly be thought to be related to SVT. However, technically, it is a form of supraventricular tachycardia. And here there is some circuit of electrical activity that occurs in the common or typical type in the right atrium, which whizzes around often at about 300 beats per minute, sending impulses to the AV node at 300 beats. Now, the AV node knows not to transmit those to the ventricles, because if our pulse goes to 300 beats a minute, we're not going to survive very long like that at all. So what it does is it may ignore every other impulse and only transmit at 150, or ignore two impulses and then let the third one through, therefore transmitting with a heart rate of 100, or fourth impulse 75, and so on. But it is quite common for the heart rate to get a little stuck at 150 with every second impulse being transmitted through to the ventricles. Here's an example of the sort of patient that we might see. So what will happen when we see these people at their appointment? Well, the first thing we'll do is ask them about their symptoms. When did they start? How often do you get the symptoms? Do they occur continuously? Very unusual. Or are they occasional? And if they are occasional, what, if anything, triggers the symptoms? Have you identified anything that triggers these? Often people will look hard. Some people may find that certain things trigger them. In some people, for example, caffeine may be a trigger, but it's not commonly in my experience. In my experience, often it's nothing at all that triggers them that they can recognize, and they just occur spontaneously. Importantly, does anything relieve them, or does anything else aggravate them? The relieving, some people have identified a way of performing the vagal or valsalva maneuvers themselves by coughing or holding their breath. And it's often important if they can tell us that, because that points us in the direction of the two types of arrhythmia, AVNRT and AVRT, that respond to those sorts of maneuvers rather than the other types that I've mentioned. Importantly, how do the symptoms affect your lifestyle? Because we'll want to know that. If they don't affect one's lifestyle very much at all, perhaps if people can control them with a little breath hold maneuver, someone may choose to do nothing at all about them. I've already said that they don't increase risk of heart attack or stroke, and that would be very reasonable. But if they're completely debilitating the person, or even if they're not very frequent, but when they occur, they cause them a lot of symptoms, or they cause a lot of anxiety to the individual because they're always waiting for these to occur, then it may be they choose to do something more about it. Much of the rest of the information we need will be in the referral that's sent to us by the general practitioner. One of the other things we'll ask is, what does the person mean by palpitations? Because people mean different things. Some people just mean an irregular heartbeat. Some people mean a fast heartbeat. Some people even mean a missed beat. Some of the things that might help us work out which of these types of rhythm problems is the cause of that individual's SVT are how the rhythm starts and how it stops. If it starts very suddenly and stops very suddenly, that makes the AV nodal reentrant tachycardia or AV reentrant tachycardia much more likely. If it fairly gradually comes on over a short period of time and fairly gradually stops over a period of time as well, then we tend to think of some of the other arrhythmias. If it's very brief, it may not be an SVT at all. If it's a sensation of a missed beat, then it may well often be what we refer to as ectopy or extra beats. But if it's more sustained, then it may be any of the types of SVT that I've already mentioned. And as I've already said, if the person's already discovered a way of holding their breath or doing something to stop it that makes us think that it's a Valsalva type maneuver, then that makes these two types of arrhythmia, AVNRT or AVRT, much more likely. We're always interested in other symptoms as well, because if someone is feeling like they're about to black out with them, we probably have more concern. If people are able to tolerate them very well, then we can reassure them. The examination of a patient in this scenario is often normal, although we'll often perform an ultrasound scan of the heart just to confirm that the heart really is working completely normally structurally, and this is purely an electrical problem. If it's triggered by exercise or by doing certain things, then we can probably try and reproduce that, because for us it's really helpful to try and catch the abnormal rhythm on an ECG. We'll do a normal ECG anyway, and some people will do blood tests, and some people perform monitoring depending on the frequency of the symptoms. So how can you help your doctor if you have a possible SVT mechanism when you see them, particularly when you see us as electrophysiologists? Well, be precise as you can. We appreciate, though, it is not always easy to be precise. So do make some short notes about how frequently you get it, how long they are on average, shortest, longest, if there are any precipitating factors or any relieving factors. Please do bring your medication list with you, including the doses. If you want to, bring the boxes as well so we can have a look at them. But if you bring a list with your doses, that's very helpful if you're on any medication at all. Many people won't be on any medication though. If someone's seen you having this, that can be helpful sometimes if people black out and aren't aware of it. But I've already said that blacking out is pretty unusual. And most of the time we can get all the information we need from the individual themselves who's suffering from the SVT. If you do have any correspondence that refers to treatment you've had from other doctors about this particular condition, or indeed any other condition, but particularly this condition, including any investigations you've had like ECGs, if someone has managed to actually capture the rhythm problem on an ECG and given you a copy, then please bring that along, because that's very helpful. And if you do have those ECGs done at another hospital, then please ask them for a copy when they're done. Everyone should be given a copy of their ECG, their normal one and any abnormal ones ideally, so they can keep them as a record and bring them to anyone else who sees them. So how do we manage SVT? Well, there are some common themes to all of these arrhythmias. In terms of emergency, or what I call acute management, actually, because most people tolerate these pretty well, that's not very common, but just occasionally they will present as emergencies and we'll deal with those. Most people, though, when we see them in the clinic, will be reassuring them, particularly if their hearts are otherwise normal. We might be offering them the so-called pill-in-the-pocket approach. A few we may offer regular medication. As I mentioned, a few we'll talk to about electrophysiology studies and catheter ablation. Let's just talk about those for a moment. And specifically, we're really referring to the AVNRT, AVRT, and possibly atrial tachycardia. Not really atrial fibrillation, possibly atrial flutter as well. Now, these are day case procedures. often done with just some sedation, so something just to keep the person relaxed. We take the individual into a special room and lie them on a couch. We hook them up to lots of monitoring equipment. Once they're hooked up to that equipment, we start to give them the medication to relax them. We cover them from neck to toe with a light sterile towel. And then we use some local anesthetic to numb the skin at the top of the legs, just in the creases of the groins. Once that's done, we can insert some very small tubes into the veins in the legs, a bit like a bigger version of the drips or cannulas we put in people's hands to give them medication. And through those, we can feed some very fine little catheters or wires. And here we see an X-ray image, if you like, of these wires inside the heart. These are only a few millimeters in diameter, and these black dots represent little metal rings on these wires that when they come into contact with the tissue, measure the electrical signal in the hearts. And by positioning these in the heart in certain places, we can measure the electrical signals traveling through the heart. We can add little extra beats, which is completely painless. And we can often make the heart go fast as it would do, but in a very controlled fashion. We can literally start it and stop it. We won't let it make the person uncomfortable. Importantly, once we've identified the problem, we can then use a special catheter called an ablation catheter to normally, quite commonly, cauterize or burn the little bit of tissue that is causing the problem. So for example, with AVNRT, it would be the extra nodal pathway that we would ablate, or in AVRT, where the person's born with an accessory pathway, we ablate the accessory pathway. And in these individuals, we can actually cure them in the vast majority of cases with a single procedure. Very occasionally, we have to do another procedure. I've mentioned down here 5 to 10%. It's probably much lower than that these days. Importantly, in terms of serious risk, the risk of a serious problem such as a heart attack or stroke, it is extremely low, less than 1 in 2,000, which I would tell you is really quite low. One of the main concerns, however, is that there is a small risk of damaging the normal electrical system whilst trying to ablate the abnormal. And in those cases, a small number of people need what is referred to as a PPM or permanent pacemaker. But that risk is small and it will vary from individual to individual. So that should be discussed by the electrophysiologist with the patient. It is true, though, that we won't often be able to tell you exactly what that risk is until we're doing the procedure. So there has to be an element of trust between the doctor and the patient to make sure we keep that risk low. And once we're done, all of the catheters and wires are removed. There's no stitches. People rest in a bed for a number of hours and may often walk out the same day. But we ask them to take it a little easy for up to a week. Generally, we suggest no driving for a week, although the DVLA will tell you it's only illegal for 48 hours. And other advice about work and exercise we will give to people at the time of the procedure. But generally, again, our advice is to try and relax, keep things to a minimum in terms of work and exercise, probably for about a week. So in summary, supraventricular tachycardia, what is it? Well, hopefully I've given you an answer about that. Simple, perhaps. The simple thing is that it tends to refer to AVNRT and AVRT, although the other 4 rhythms all come under that umbrella. What do we do about it? Well, we have to recognize there are different types of SVT. There are some similarities and differences between them. In some people, they can be very debilitating, but in the vast majority, as I've said before, these are not life-threatening. So please do not worry if you have this. We can manage this with you. It is very helpful if people with a possible diagnosis or even a definite diagnosis of SVT who are coming to see us are prepared, are able to give us a good story, tell us what medication they're taking, and if they have any ECG recordings particularly, it's very helpful to bring those along. And finally, as always, there are some very valuable information resources on the internet, and I can thoroughly recommend the Arrhythmia Alliance's website and the leaflets they have there, which will give you a lot of useful information. Thank you very much.